Very good afternoon. I would just quickly take you through in the following slides. I will take you through the basic protocols for recording electroretinogram, electrooculogram, and visual evoked potential. Now, first of all, we should know why we need a standard reporting, because electrodiagnostic tests are highly variable. They vary with age, gender, ocular status, testing condition, technology used, and protocol followed, and the level of artifacts. There should be an uniformity and comparability of the data worldwide. The consistency of the results within and between the test centers can be ensured only by following a common testing protocol. So, the full-field electroretinogram or simply electroretinogram setup looks like this. So, this is the Ganzfeld stimulator, which stimulates the entire visual, the entire retina. It's a electroretinogram is a pan-retinal response generated by stimulating the retina with lights of different intensity in different adapting conditions. So, these are the electrodes available. The active electrodes include the corneal or skin electrodes. The most commonly and the steady and the consistent recordings are with Burian-Allen electrode, which is a bipolar electrode where active and reference electrodes both are incorporated within the same. As we can see here, the pupils are fully dilated for the maximum area of retina to be stimulated. This is the stimulator, these are the electrodes, and usually it's a test, the interpreter or the technician's choice whether to start with scotopic or the photopic. So basically these tests are done during dark as well as light. The dark adaptation period for at least 20 minutes and a light period adaptation period of around 10 minutes. So we usually start with dark adaptation and followed by the recording in the dark phase, for then light adaptation and recording in the light phase. So this is the handheld device that can also do the electroretinogram recording, and especially useful. It is a small device which can be taken to your operating room, and especially in the children, and it can be done both in the awake as well as under anesthesia. So these are the basic these are the 6 basic phases of electroretinogram, that is one is 0.01 ERG scotopic, 3.0 scotopic, then 10.0 ERG scotopic, oscillatory potential, then 2 photopic phases, that is 3.0 photopic and 30 Hertz flicker. So now how should we interpret these reports? So whenever we get a report, first the demographic details should be analyzed. Then the recording details, probably the protocol followed, the machine used, the electrodes used, and the pupillary dilatation, and also the level of compliance and cooperation of the subjects, because they can vary the results, and if we are not careful about that, then we might misinterpret, wrongly misinterpret a true signal or a false signal as a true signal. Then the patterns, are they, how are the pattern, are they preserved? Do they follow what is expected, and are there any artifacts? Finally, individual responses, they should be measured in terms of the amplitude and latency and compared with the normative data for that laboratory and for that setup. Finally, electrophysiologist remark. Now, electrooculogram is again another pan-retinal response that specifically tests the retinal pigment epithelium, but it is practically impossible to isolate the retinal pigment epithelium activity alone. So it in general assesses the retinal pigment epithelium and photoreceptor complex. In normal resting stage, the eye acts like a dipole. Cornea is positive with respect to negative retina. So during the phases of dark and light, if the eyeballs are made to move, there is a steady change in the electrical potential, and these when the eyeball moves periodically from the plus to the negative minus pole, the waveforms take a square shaped waveform where with a peak here and trough here, and these square waveforms during the phase of dark adaptation, they slowly decrease to reach the lowest level called as dark trough, and during the light adaptation they increase and reach a light maximum in the light phase around 8 to 10 minutes after the light adaptation. So this is how, this is the brief summary of the protocol. 15 minutes in the dark, 15 minutes in the light. These are the fixation targets kept separated by around 30 degree. The subject with the skin electrodes periodically rotates the eyeballs between these two targets. So 15 minutes during the dark and 15 minutes during the light. And in every minute the movements happen for around 10 seconds. So another 50 to 45 seconds patient takes rest. So these the waveforms take the shape of this, like the square shape waveforms, and there is a monitor to track the eye and see the level of cooperation. The report looks like this. How should we read these reports? First, the demographic detail, the testing condition, testing parameter, protocol followed by the sockets. Do they conform to the square shaped pattern like a top and a bottom or not? Second, how do the waveforms look like? So this is a sinusoidal plot. Normally when the peaks and troughs, the waveforms are connected to each other, they take the shape of this. And finally the light peak and the dark trough, light peak time and the Arden ratio. So sometimes when there is another protocol called as fast oscillation, which has a just opposite polarity to the classical slow oscillation than EOG. Usually I use them in the children where the recording time is very brief. So I will take this. There are a few precautions. Sometimes the electrodes, when they touch each other, can falsely affect the recording. So as kissing electrode showing the wrongly low value. On correcting this, this comes again. So coming to the visually evoked potential, it's a response of the entire visual system to a plus or a pattern stimulus. So basically the recording protocol should include at least any one of these following, either a flash or a pattern stimulus. The pattern stimulus can be pattern onset or a pattern onset offset or a pattern reversal. In the pattern reversal, the checkerboards are different size, they alternate with time. And flash visual evoked potential is useful when in cases of poor optics, poor vision or poor cooperation, they are of less value. They just give an impression that some light is going through the visual system. So this is the setup. The electrodes are skin electrodes are placed in the midline with a single channel recording. So with the 10-20 system, like the active electrode is placed over the occipital cortex, and the reference electrode is here. And this is the setup. They are connected to the amplifier, and this is the handheld device. The same thing can be recorded the handheld device. So visual evoked potential, these are the signals extracted from the ongoing electroencephalographic activity in the visual cortex. So we should be careful that some response doesn't mean that there is good health, the optic nerve or the visual pathway is healthy. For example, if you see here, the subject is not looking at the stimulus, but still there is some recording. So this recording is not reproducible and it is not what is expected. So this is a false recording. One should be careful, because the ERG in VEP, whatever we are collecting the visual, those responses evoked by the visual stimulus as well as electroencephalographic activity. So these are the various waveforms, like pattern VEP, the P100, which is the most constant one and is used frequently. The flash VEP, N1, P1 and N2, P2. The P2, N2, P2 are the most commonly looked for. Compared to the absolute values, it is the reproducibility and symmetricity between the eyes that count, that help a lot in seeing whether there is a response or not in flash VEP. The pattern onset offset is used mainly for the malingerers or those with nystagmus. They have a opposite polarity to that of pattern VEP. So finally, we can see case of, this is just a representative case, 19-year-old male with head injury, no light perception. There is some responses here, but actually they are not reproducible. They are not the way we expect. These are just noises, not actual responses. Similarly, another subject, 62-year-old male with right eye counting finger 1 meter distance, left eye 20/20. We can see that the waveforms are stunted as well as with increase in the latency in the right eye. So, thought up as the optic neuritis, the patient was about to go, but when we looked at the retina, we can see that the inner retinal layers are atrophied, and it was a case of actually central retinal occlusion, which is presenting with stunted visual evoked potential. So, these tests need to be taken along with other objective tests of macular function. So, I thank you all. I can take a few quick questions.
Thank you, Dr. Tapas. I'll invite Dr. Jalali to please chair the session, and Dr. Parveen also. Please, ma'am. So after the basic testing protocols, if anybody has any questions or comments. Sorry, ma'am, मैं आपको call कर रही थी. हाँ जी, ma'am. Please, मैं बैठी हूँ. Ma'am, we'll have the keynote now, and फिर artifacts कर लेंगे.
Hello. Okay, so it's my distinct pleasure to invite Dr. Sandeep Grover to give us the keynote address in this session on the role of ERG in inherited retinal diseases. Sandeep, thank you for being with us and not canceling your trip like many other people have done, so it's commendable. Welcome.
Thank you very much. First of all, thanks to Dr. Lalit Verma, Dr. Neha, Dr. Subhadra for inviting me to share some things with you. So I'm at the University of Florida. I used to practice in Delhi way back in 1990s, then decided to move to USA for different purposes, and then did a few fellowships with inherited disease with Jerry Fishman in Chicago. And that's where it became my passion. And then repeated my residency in Chicago, did 1-year fellowship in medical retina. Then since 2005, for last 15 years, I've been at the University of Florida. So the point is that electroretinogram or full field ERG is a great tool. Can you hear me? Okay. So it's a great tool. It also depends on how we use it though. And so it's important for us to know when to order an ERG. So when do we order ERGs? Well, one, to diagnose inherited retinal diseases. Sometimes it helps in the diagnosis. Sometimes it helps to establish the prognosis of a certain condition. It is obviously a very useful tool to establish natural history of diseases, especially nowadays because, with the treatment trials being planned, you absolutely have to know the natural history of certain diseases. And then, of course, in treatment trials, ERG is definitely used as one of the endpoints. So it is very easy when you see these fundus pictures and you say, that's Stargardt disease or that's retinitis pigmentosa, because phenotypically you can identify those. It becomes a problem when the retina can look similar, yet there are two different diseases. So that's when the testing becomes very important. But before, and I teach my residents this thing, before you jump on and become excited, oh, there's a macular lesion, the important thing is refraction, refraction, and refraction, especially in children. That's very, very important. If they do not have any macular findings or the retina looks normal, but the vision is down, the first thing to do is refraction, because so many times is nothing there except a refractive error which someone missed. Broadly, you can classify children who have a normal looking fundus with decreased vision into children who have nystagmus and who do not have nystagmus. And without nystagmus, usually cone rod dystrophy and Stargardt disease are the common ones. Although very early cone rod dystrophy or cone dystrophy can present with nystagmus as well. The important conditions to look for with nystagmus are achromatopsia labor congenital amaurosis, and congenital stationary night blindness. So let's look at certain scenarios. I have 10 minutes, correct? Okay, thanks. So let's look at the few scenarios here, few cases. So this is a 12-year-old Afro-American boy who came in referred because he had some kind of a retinal degeneration in the right eye, has decreased vision in the right eye, also some in the left for a couple of years. His older brother was diagnosed to have Stargardt disease. There was no other history of any other problems, and especially no history of any trauma. The vision was 660 in the right eye and 612 in the left. He's a myope and some astigmatism. And this is what his retina looked like. And as you can see, the right eye, it shows extensive retinal degeneration with pigmentary changes, macular changes. And this was his visual field with superior and nasal visual field loss. And this was his left eye, which looked kind of normal. I say kind of normal because we'll see what the abnormality was. We did an ERG to establish the diagnosis, and the top two show the right eye, the recordings from the right eye. The bottom two show the recordings of the left eye. And as you can see, the right eye pretty much is non-recordable, although there is a wave amplitude there. But the left eye, you can see the A wave goes down, but the B wave does not come up, which kind of establishes the diagnosis of X-linked juvenile retinoschisis. And that is, we call the selective B wave reduction or a negative ERG. Of course, nowadays you have an even better tool of OCT, and even before you do an ERG, you can establish the diagnosis. But ERG is definitely confirmatory. And this was the peripheral retina, where it is known that people with X-linked juvenile retinoschisis, 50% of them can have peripheral retinal schisis as well, which gave that visual field defect. Another 15-year-old boy complained of decreased vision. The vision was 660 in each eye. Color vision was down. So you think about certain conditions, cone rod dystrophy, Stargardt disease, although Stargardt disease does not affect the color vision as such, but it can. So did the ERG, and the ERGs on the right side column are the normal amplitudes and implicit times, whereas on the left side is from the patient. And just to focus on the photopic white that Dr. Tapas very nicely introduced the ERG to you all. So we're looking at the cone function when we say photopic white, flash. And as you can see, it was a non-recordable cone function. And also the flicker, which is for the cone function, the flicker was down. Then you look at the rod function, and it was recordable, but it was decreased as compared to normal. So based on that, you could say that this is cone rod dystrophy because the cones are more affected than the rods. Another 8-year-old boy with photophobia and nystagmus, 660 in each eye. The retina pretty much looks normal except for hypopigmentary changes all over, but it looks normal. There are no pigmentary disturbances, and the boy has nystagmus. So we do an ERG, and the bottom line is for the cones, which you can see all three were non-recordable. The rod function on the top was pretty much normal. So based upon the fact that the cones are affected, the child has nystagmus, that points towards the diagnosis of achromatopsia. So you think about achromatopsia with decreased vision, nystagmus, and photophobia, which is usually severe. In fact, a 6-month-old you can diagnose by just when the baby comes in, the light is on, and the baby is doing this. The moment you switch the light off, the eyes are open. That's achromatopsia until unless proven otherwise. So this boy comes in 1 year later with the history of bumping into things. Now, that is not a characteristic feature of achromatopsia because in achromats, the cones are affected, but the rods are not. So we decided to, did the fundus exam, of course. We saw a little bit of mottling in the peripheral retina and did the ERG. And now if you compare the ERG from the top and the bottom, the cones are still not there, but the rods, the amplitudes were less. So actually this patient had a cone rod dystrophy, which initially presented as achromatopsia. The point is that sometimes the cones can be affected and the rods can be affected later on, so you always have to keep that option open. And I always tell the parents that, okay, this is achromatopsia, but we need to monitor this child. And of course, you can nowadays do gene testing and sort of confirm it. Another patient, 40-year-old male, night vision problems as long as he remembers, side vision problems since age 10, and several other family members were affected with retinitis pigmentosa. And this was his right and left eyes, which shows the typical waxy pale disc, attenuated arterioles, but he did not show too much bone spicule pigmentary changes in the retina, and the vision was good. We did a ERG, and on the left side is the rod function, the right side is the cone function. On each one of them, the left column is the normal, the right column is from the patient. So you can see pretty much the rod function and the cone function was non-recordable. So very severe retinitis pigmentosa. I don't have the fields, but the fields were like central 10 degrees, so-called tunnel vision. So severe RP, not too much pigmentary change, but this helped to establish the prognosis of the disease. A similar 40-year-old patient, Hispanic, also presented for diagnosis of RP, at least 25 years of history, and vision was fine. And this was the pigmentary change. As you can see, more along the arcades, not too much in the periphery or the macular area, and similarly in the left eye. And the visual field showed a very posterior ring scotoma, but the peripheral fields are pretty good. And this is the other eye, sorry, similar pattern. And then you look at the ERG, as compared to the normal, there was recordable ERG function. That's the rod function. And then this is the cone function. So yes, the rod and cones were decreased, points towards the retinitis pigmentosa diagnosis, but the prognosis is definitely better. And 10 years later, this patient still has the same vision, similar visual fields, and similar ERGs. So prognosis is much better. That's the point, is that the ERG sometimes helps to establish the prognosis. And very important to remember, the severity of the disease is not reflected by the amount of pigmentary change in the retina. So some people can have hardly any pigments, yet severe disease, as we just saw, and some of them have quite a bit of pigment, but better prognosis. Another patient, 50-year-old male with 6 months history of driving difficulty at night, noticed areas of grayness in the peripheral fields. No other complaints, vision was good. This was his retinas, and which looked pretty normal. But the fundus autofluorescence did show that there was hypoautofluorescence along the arcades. And again, just 6 months history of night vision issues. He also had these posterior ring scotomas. The light adapted response, so we can see the light adapted responses were reduced. And if we look at the dark adapted response, the rods, the pure rod function was pretty much non-recordable, but again, if you look at the rod, predominantly rod area, there was an A wave, but the B wave did not form. So there's a whole differential of selective B wave reduction, one you already saw. And looking at all these points, I decided to send antibodies, looking for retinal antibodies for Carr syndrome, Marsh syndrome, etc. And these antibodies did come back positive. So the ERG actually established, initially I was thinking it's a form of retinitis pigmentosa, but the ERG did establish that there was a selective B wave reduction, and there's autoimmune retinopathy and cancer-associated retinopathy. There's no history of any cancers or melanoma in the patient. There's a history of 2 moles that were taken out in the past, one from the back, one from the foot. Colonoscopy did not show any malignant lesions. Chest X-ray was normal, and blood workup was negative. So he didn't really show up, but we know that sometimes autoimmune retinopathy or Carr syndrome can precede the finding of any cancer in the body. And the last patient is a 10-year-old girl. Parents gave us 1 year history of decreasing vision, night vision problems. The grades at the school were going down. The pediatrician did an MRI of the brain first. Doesn't that happen with you as well? That they do the MRI first, then send to the eye doctor to look at the eyes. So MRI of the brain was normal. The best corrected visual acuity was reduced both the eyes, much more in the right eye. There was a history of uncle and a nephew having RP. There was no history of seizures, behavioral change, and motor problems. Examination pigmented cells in the vitreous, mottling of peripheral retina, but did not show bone spicule pigments. We tried to attempt visual fields. There was some concentric restriction. Did the ERG, and in the rod function, you can see that it was not too bad. And the cone function was not recordable. So this kind of set the patient in a diagnosis of cone rod dystrophy. And I told them to come back in 6 months to see how everything is going. I got a phone call 4 months later, and I saw the patient 5 months later. Rapid progression of vision loss, now hand motion in each eye. I had already alerted the patient's parents. So there was some behavioral changes, temper tantrums. Patient was emotionally labile. And when we did the ERG, it was non-recordable. Just in 5 months, it went from almost pretty normal rods, some subnormal cones, to non-recordable rods and cones. This is an important indication to test for Batten's disease. So I sent the blood for checking for Batten's disease. Patient did turn out positive for PPT1 mutation in the CLN1 gene with the following variants. Very important to identify Batten's disease because it's a fatal disease. Most of these children do not live beyond teenage years, so the parents need to know that. It was sad. Actually, this came out just last week, and I thought of including this in the presentation. So again, ERG was very, very important in this. And lastly, for treatment trials, very necessary to have ERGs for monitoring, although there is a lot of variability of full field ERG in patients. So we have to be very careful how we kind of interpret those results. There is a foundation fighting blindness in USA that actually funds a lot of research in retinitis pigmentosa and inherited diseases. So when I went to Jacksonville, I opened up a chapter in Jacksonville. So we do a vision walk. That's my team, which I call Drishti. And that's my team from last year. And that's my office. Thank you.
Thank you, Professor Grover. I think that was highly illuminating, and especially, the pictures look quite different from what we see here. And sometimes we do get lightly pigmented patients, and then it doesn't look like what it looks in the Indians. So I think that those images and pictures for everybody very important to see different colored fundus that helps us in many more patients. And of course, the ERGs are beautiful. Thank you.
Thank you for a very good talk, Dr. Sandeep. Just one thing, what probably I would also, we learned from his talk that a lot of investigations have to be taken in tandem. One, autofluorescence very nicely complements ERG, and OCT complements the other two. So none of the single things can be taken in isolation. And I think the carry home message is not to try and label or diagnose any disease, especially in a young child, because it's a disease in evolution. So I have also burnt my hands. You try and say that it is cone disease, or it is something at 9 or 10 years, and finally it becomes cone rod and then becomes RP. So the prognosis and everything changes. So at that age, we need to be very careful when we are interpreting our ERGs. Till we have seen the progression, I think we should not label a diagnosis to them. We'll go to the next one. So I request Dr. Subhadra to please give us her talk. She's a senior consultant at Dr. LBPI, needs no introduction. The amount of work that she's done in ERG along with pediatric retina speaks volume of her dedication.
Okay. We need to get these tables of our height. They're all men-sized tables. And now they have started raising these tables. I can't even see myself. Okay, so I'm just going to be very brief about the interpretation and what variations we see in ERG. So the variations could be physiological, technical, and sometimes pathological, as we just saw in that patient with neuronal disease. If you have taken the ERG at a different phase of the disease, you will get totally different things. So we should be aware of that. So there's a huge list of things that cause these physiological changes. I'll just tell briefly some of them. What Praveen just now said, that if you have children, then the ERG should be interpreted with caution. So I have seen so many children labeled as blind because the ERG was not recordable or the VP was not recordable. I don't know, there's some echo. Can we have the door closed? Or ye echo thoda kam kari? I don't know why that echo is coming. Okay. So the ERG does increase with age, and so we have to be very careful when we interpret. So if you get a good recording, it's good, but if you don't get a good recording, don't say that this is poor prognosis, ask for repeat testing at another point of time. So the age and ERG, you can see here that there is a change of about 100 microvolts by the time the person becomes older. The gender, there is higher B wave amplitude in women, and possibly this is because of the smaller axial length, and there could be a 30 to 40 microvolt difference. So in your normative data, it's good to have the males and females of different age groups. The refractive error, a lot of work has gone in myopia and ERG, and sometimes very difficult in our situation because we have a lot of retinal dystrophy, both RP and CSNB, to correlate whether this is a retinal dystrophy or it's just because of high myopia. Because you can see here, high myopes, they get very low amplitudes and low implicit times. And there's less work done in hyperopes, but we know that hyperopes will get more of high amplitude. But again, there's that's a good case studies to do. There is a lot of retest variability. Sandeep also talked about this. So to test once and then when we test again the same patient at the same time, even up to 25 to 50% variability can occur just because of retest variability. So ICER requires us to have at least 2 reproducible waveforms, but it's not necessary that the next time you check this patient you will get very close. The good thing about diseases is that in most of the retinal diseases, a pathological ERG is very different from a physiological difference because there not only the waveforms change and also the amplitudes and the implicit times change quite drastically, especially in diffuse retinal dystrophies. So just a reduction of amplitude should not tell us that there is a disease or the disease has worsened. There's also diurnal variation, just like for visual acuity and IOP, there's a diurnal variation. So if you're doing a study, then it's better to do it at the same time of the day as far as possible. We all know that if there's media haze, if there's a pupil which is not dilating, then you need to account for that because that can lead to longer implicit time and reduced amplitude. So if you are looking at somebody who has a uveitis and the pupil has got bound down, that itself will affect. And if there's silicone oil, please don't try ERG because it will most commonly come out flat. So ERG in a silicone filled eye is not going to give you any information whether that eye has potential for vision or not because oil is a poor conductor. The amplitudes increase when there's less pigment in the retina. So albinos actually will have very high amplitudes. We don't have good data on Asian Indians where they fall, but I think they should be falling in between the people who have white retina and a black retina, depending on from which part of the country they come from. Dark adaptation state, again, some people try to do shortened dark adaptation. So especially if you've looked at that retina with some imaging device, like FFA or light-based systems, then the ERG is going to come different. So try to do ERG on a day or time when you've not examined the retina. And if you want to take fundus photographs, you can take it after the test is done. Then of course we should always ask for any medications which change the blood flow, change the blood pressure, change the caliber of the vessels, then they can have profound influences, especially general anesthetics and other drugs. So we should account for these. Also patients who are on dialysis, they would have different ERG. Then coming to technical causes, I think electrodes are the most important. I have just put here as something like a blink artifact. So how do you know that it's an artifact? One, because it's not reproducible. So we've recorded twice and it has come different each time. And second, there is no ERG which comes so late. So both the timing and the non-reproducibility reproducibility tell you that this is an artifact and this is not a true waveform. Now electrodes which are closer to the cornea, such as the Burian-Allen or jet electrodes, will have higher amplitudes than what we use here, the Zari electrode or the DTL electrode. So it's very important for the fiber electrodes to be as close to the limbus but not crossing the cornea, so that you get better amplitudes. And of course the stimulus parameters, what type of machine we are using, what type of the light is coming, that would also matter. So that's why it's important to have your own normative data. You can use the machine data for some time till you build up your own normative data. So I already said that there could be pathological variations. For example, in sidrosis, where there's a localized sidrosis, you can see that the waveforms were good. But in advanced sidrosis, it became flat. So again here, this is a true wave, but this is a blink artifact because it's not reproducible and it's coming quite late. So we should, like this patient, he was referred as like he has very good response. This is not a good response. This is an artifact which is there. So again, patients who have cone dysfunctions, they will have a lot of these artifacts. They will keep on coming up and they will look like waveforms. And sometimes they can be reproducible also. So it's not that the patient can just blink at the same time every time. And you can have reproducible artifacts also, but the timing will tell you that this is not a true response. Now here we have a patient whom we are testing, and here you can see that it seems as if he's got a lot of responses. Now these are not responses, these are the 60 Hertz line artifacts. This is all because there is not good grounding or there is no earthing, and so there is some response here which is abnormal, but we can see that it has got contaminated with the other line responses. So we should not measure these, and then we need to correct some of the things. So I think the causes of artifacts briefly are patient factors, like if the patient has eccentric or poor fixation, this is especially for the pattern ERG or multifocal ERG, or patient has eye movements, or there is orbicular contraction, or even cervical muscle contraction. So how the patient sits, whether their muscles are relaxed or not, if they are very tense like that, bound up, it can cause contamination of your recording. Then inadequate transparency of the corneal electrode, or if there's poor quality, like we are using Zari, but if it has frailed and it has become bad Zari, then it will not give a good response. If there is inadequate viewing distance, like patient is not using the refractive error or is not at the correct distance, then you will get artifacts. And as also if the patient is not sitting at the height where he is supposed to sit, but he is low down or up down, then you will not get the good recording. So these simple things the technicians can avoid. And then there are other factors, as I said, the electrical noise and the electrical field which is around them, and the high impedance. So every recording we should check the impedance first, make sure that the baseline is good, and then do the recording. So sometimes we use excessive filters. So when there's too much of response, we use filters to move these out, the waveforms. So this can sometimes artificially change the analysis. So it's better to treat the cause rather than just put in filters and do the averaging to reduce your artifacts. So I think here we are saying that just because there's a hot spice girl, we should be speaking the same language and make sure there's no artifact, and we understand the system and realize what it is telling us and giving to us. Thank you.
Thank you for a very nice talk, ma'am. I think because of paucity of time, we'll take the questions towards the end of the session. Can we go to the next speaker, Dr. Neha? She needs no introduction again. She's the chairperson of this session and has done a lot of work in ERG in the last few years. She'll be talking to us on decision making in electrophysiology, which test to order and when. So while Neha is preparing for her PPT, just a little comment to the previous talk that we had on artifacts. So I think another important thing is to always look at the resistance which the machine will show you as to what is the resistance once your electrodes have been put in place. So if it is anything beyond the acceptable norm that you have for your clinic, maybe something around 5 or 6 ohms. So if it is more than that, you already know that your interpretation has to be taken under those circumstances, and you need to account for it that the resistance was high. Okay, over to Dr. Neha.
Sorry about that. So as I was saying, which tests to order when, how to interpret them, and what are the caveats. So I've taken 5 common clinical case scenarios which we each of us encounter, and let's go through them. So nyctalopia, retinitis pigmentosa, already been talked about. It's a clinical diagnosis, and usually we get an extinguished ERG in well-established cases. But what is the role of ERG? We can use multifocal ERG to assess the residual cone function to follow up these patients. It corroborates well with the OCT. The 30 Hertz flicker can also be used because most often than not, these patients want to know the prognosis, and this can help us to do that. ERG is also important in diagnosing patients which present atypically or in early cases without typical fundus changes, and also in carrier detection. Now let's look at this patient with nyctalopia, normal fundi, normal OCT, and normal vision. So again, ERG is essential here, the full field, to establish the diagnosis. If we see here, there's a negative ERG, there's a deepening of the A wave and a flattening of the B wave with the inverse B to A ratio, and this has to be seen in the single flash response. The other protocols are normal. This is a case of CSNB type 2. So CSNB is important to identify because it is non-progressive, the visual acuity is normal, and we can reassure our patients. Of course, if the fundus is abnormal, the diagnosis is straightforward, but ERG can help us to distinguish type 1 and type 2 when the fundus is normal. So negative ERG is seen in a host of conditions which are actually those of inner retinal dysfunction. As we saw a case of XLRS, which Dr. Sandeep had showed, CSNB, and then acquired. Now CRVO is one of the diseases where ERG is very underutilized, and it's actually better than angiography to see the conversion to the ischemic state because it's unaffected by media haze, and if there are hemorrhages, that also doesn't affect the ERG. Again, CAR, another case was discussed, and MAR, ERG can be of use in pointing towards that. This is the third case of nyctalopia, again normal fundi, normal OCT, and normal vision. It does have an inverse B wave as well, but if you look again, the pattern ERG is also depressed, and so is the multifocal ERG. So this would not happen in a CSNB. This is actually a case of vitamin A deficiency, which after the ERG we retrospectively asked, and the patient was that of alcoholic liver disease. So this is another diagnosis in the spectrum of nyctalopia, and of course important because it is treatable, and the ERG changes do also reverse following treatment. Finally, sometimes we have these typical clinical pictures, though they are rare, with pathognomonic ERG like the enhanced S-cone syndrome. So remember that ERG is important whenever you suspect that there's a problem with the rods, and also remember that it's a global response, so that if there's only a macular pathology, your full field ERG will come out to be normal. The next scenario is what, the kind of dustbin diagnosis we call heretomacular degeneration. Whenever we see a macular lesion, we suspect to be a dystrophy, and this term we commonly use. So this is a young male who had decreased vision and difficult to take the fundus picture, so that's a pointer. Some EZ defects on OCT. We already know the diagnosis, but ERG will help us to confirm that it is a case of achromatopsia, and of course the color vision is affected. So as ma'am was saying, there are a lot of blink artifacts usually in these patients. In this patient there wasn't one. So coming to clinical applications of ERG, whenever you suspect photoreceptor dysfunction, which can be in the rods or cones or both, or inner retinal dysfunction, the classic negative ERG, then you must ask for a full field ERG. There are only a handful of conditions which will give you an extinguished ERG. So if you get that, then you can easily sort out your diagnosis as well. Now see this, another of those HMDs where you have macular lesions, macular scarring, decreased vision, and the full field ERG is normal. So phenotypically we know this is a case of Stargardt's disease because the PERG is very much affected. Many times we come across these patients where the diagnosis again phenotypically is clear cut, but again full field ERG helps us to prognosticate these cases. If there is more generalized involvement, then the prognosis is poorer. Another case of unexplained vision loss with just some hyperautofluorescence, which you can see in a kind of ring form. Family history was positive, and OCT shows you these subtle EZ defects, if you look carefully. So electrophysiology again helps us to point a diagnosis. In this case, the pattern ERG is normal. So anyway, we know it's not Stargardt's by the OCT. So the multifocal ERG is depressed, especially in the rings 1 to 3. So this was a case of occult macular dystrophy, which has now been recognized more as we are knowing more about it. And as we know, the fundus, autofluorescence, sometimes ERG are all normal. The only pointer is the defects on OCT and the multifocal ERG. So my point is, in hereditary degenerations, it's better to order all, depending on the visual acuity and fixation of the patient, of course. Each of these tests will give you some negative value sometimes and some positive value. Now, this is a straightforward diagnosis. Clinically, we know it looks a vitelliform lesion, and the full field ERGs are normal. The Arden ratio is decreased. So this was a case of best vitelliform dystrophy. Important to remember that along with EOG, we must always order a full field ERG as well. And sometimes we have these kind of atypical cases where, in addition to the vitelliform lesion, you have cysts in the retina. So this is again what we are recognizing more as the autosomal res bestrophinopathy, where in addition to the EOG, you see that the full field ERG is also affected. Now, the third case scenario, again very important, is that of unexplained vision loss. And in this case, the first test that should be done is a PERG or a pattern ERG. This will help you to segregate whether you're dealing with a macular disorder or a optic nerve disease. And this is the flowchart by Graham Holder, which I think all of us follow, and it really does simplify things quite a bit in our clinic. So PERG can be used to distinguish a macular and an optic nerve disorder. Of course, we should do it in any macular dystrophy, and it's also been used in glaucoma, which Dr. Goel will tell us more about. Finally, coming to toxic retinopathies, for hydroxychloroquine retinopathy, very often the patients are sent to us by the rheumatologist. So these tests should be done at baseline and then annually after 5 years, unless there are increased risk factors. Now, we must interpret all these tests together, and just based on a single subnormal value on a single test, we shouldn't recommend stopping the drug. So at least it should be repeatable and it should be progressive, and because these are very useful drugs and cheap and effective drugs for the patient. So many a times we see that just slight abnormality on multifocal ERG or OCT and the patient is asked to stop the drug. That is not recommended. So to summarize the clinical applications of multifocal ERG, in addition to hereditary retinal diseases, which we saw advanced RP, occult macular dystrophy, actually for most of our acquired macular diseases also, it can be used to test the function of the retina objectively. And it does point to the pathophysiology also in diabetic retinopathy, which is now more and more being recognized as a neuronal cell dysfunction. We ourselves have done this study which has shown that there are defects or deficiencies on multifocal ERG independent of OCT, which may have future therapeutic implications as well. Again, in patients with MACTEL, it does localize the defect to the bipolar cell layer. But please do remember that multifocal ERG should not be interpreted in isolation. A full field or pattern should also be done in accordance. Now, the final case scenario, optic nerve disorders. We know that VEP is the one we turn to in such cases, but I'm starting with the caveats first because I think VEP has more of these. Please remember that VEP is dominated by the central visual field, so you must rule out macular pathologies if you have an abnormal VEP. Also, it can only detect prechiasmal diseases. So if the patient still has a problem and your VEP is normal, probably you're dealing with a post-chiasmal disorder. So I'll just skip this because of time. We know in optic neuritis, and probably Dr. Goel will deal with it. Just one thing I wanted to share, which I recently read about when I was encountered with the patient, is that cyclosporine can cause optic neuropathy. It's a drug very commonly used for skin disease, and I realized this when I was faced with the patient of cyclosporine toxic neuropathy. And on reviewing the literature, pattern VEP has actually been recommended as a tool in patients who are on long-term cyclosporine therapy to know when optic neuropathy has started. So to conclude, electrophysiology does have a role despite advances in retinal imaging, and I hope all of us will take back something home from this session today. Thank you.
Thank you, Dr. Neha, for a very comprehensive talk. I invite Dr. Puran Chandra to please come for his talk in incorporating electrophysiology in retinal practice. We have to postpone the questions, I am afraid. We are running short of time.
So good afternoon, everyone. Well, they're sitting up. Thank you, Dr. Neha and Dr. Lalit Verma, for giving me the chance. Okay. And when Dr. Neha gave me this topic, she strictly told me no dystrophies. Dr. Grover is doing that. So there could be some overlap. Yeah, Purna Chandra. This row. So incorporating finally the electrical activity in the visual system, which converts the image of a beautiful picture into meaningful signal. So for the brain to understand and eventually for us to get a wonderful perception called seeing. So basically it requires the whole functional circuit to be intact. If you want to incorporate electrophysiology in your routine retina practice, we need to follow one dictum. So that, it's not working. Okay, so this is the, whatever that appears structurally normal doesn't mean it's functionally normal, okay? So this was taught to me by Professor Graham when I was in Moorfields. So we need to remember this, whatever that appears structurally normal doesn't mean that it's functionally normal. It may behave completely different, okay? So to stress the same, let me begin with few of the case example. This was a 54-year-old male housewife, came for cataract surgery. She was interested in multifocal. So she had a past history of taking hydroxychloroquine for almost 20 years. So fundus, OCT, absolutely normal. So autofluorescence, very subtle changes. So when you did a multifocal ARG, definitely there were some depressed points in the center. At this point, I would not advise her to stop the chloroquine unless I have a corroboratory evidence with 10-2 and OCT, but definitely not a candidate for multifocal IOL. So these patients are prone to develop more glare if you end up implanting multifocal IOLs. So the second case was a 20-year-old male who came for a routine checkup. No complaints, vision 6/9. Okay, so our resident brought to me, sir, there is something in this thing, there is some meds or whatever flex-like deposits. So we did an OCT, absolutely normal. So ERG, absolutely normal. So this is nothing but just a benign flecked retina. Okay, we need not do anything, we need to just follow up this patient. Okay. So similar case, 36-year-old male, vision 6/6 and 6. Had some whitish deposits in the mid-periphery, but in addition, this patient had some history of night vision problem. So OCT again absolutely normal. So we did an ERG. So this is the ERG, the whatever the blue color, that is our normative data, and all these recordings were repeatable. I want to make this statement. So this is the ERG. If you can see that the dark adapted 0.01 ARG was unrecordable, and you see this funny A wave forming and B wave is failing to reach even the baseline. The classic electronegative ERG. So what we get in few of the congenital stationary night blindness. So basically this was a case of fundus albipunctatus, which is a form of congenital stationary night blindness, which Dr. Neha just described. The fourth case was a 26-year-old male who presented with history of low vision since childhood, the vision of 6/24, and near vision was quite okay, N6. So this was his fundus. So had atrophic macular lesion. In fact, it had almost an excavated lesion over the fovea when we did an OCT. Left eye just the foveal atrophy with outer retinal loss. So we did an full field ERG, which was almost okay. So basically what it's indicating is this lesion is localized to the fovea, rest of the retina is functionally intact. Basically that's compensating for the lost foveal structures. So this was a case of toxoplasma scar. So and that given the vision is 6/20, not that bad for a lesion. So indicating most likely it's an intrauterine lesion. Maybe from birth the patient has extrafoveal fusion. So the fifth case was this is a very interesting case. 26-year-old male, recently married, brought by husband. So telling that she is quite inattentive to the surroundings. No positive family history. They visited all ophthalmologists everywhere. They are telling her vision is still, we don't know what's her exact vision. Sometimes she tells she's 660, 3/62. See, basically she's not at all cooperative for examination. She tells I am normal. I don't have any issues. This is her fundus, absolutely normal. OCT again normal. Okay, then I did okay. OCT is normal. Next thing what we do is ERG. So autofluorescence again normal. We thought maybe malingering. So before, we should never label a patient as malingering without doing an electrophysiological test. So we did an ERG. So this was the thing. She has had unrecordable cone responses. This was a case of achromatopsia. So this is the usual OCT picture, what you see with the foveal thinning with the subfoveal cavitation. So this patient did not have any of that. So I went back and searched for it. This is the video of the OCT. You can see it's absolutely normal. No foveal defects. So this is the first case of achromatopsia which at least I have seen with no structural changes at all in the fovea. Absolutely normal. So it's applying for divorce. Maybe this ERG will help us into whatever. So the last case, this was a 46-year-old male, routine screening, 612. So our fellow did a OCT and is excited, sir, I saw a case which resembles an achromatopsia, maybe achromatopsia. He did an ERG, absolutely normal. This is just a case of solar retinopathy, what we see. Just see, it just resembles the photic retinopathy. When you do an electrophysiology, functionally is so much different. In one case, cones are absolutely non-functional. Another case, it's normal. So I would like to end my talk by quoting these two case examples. These two patients presented with history of blurred vision. One had photophobia, other had only blurring of vision. Fundus was absolutely normal again. The first patient had subtle foveal autofluorescence changes. OCT showed subfoveal cavitation. When he did an ERG, the dark adapted response was completely normal, whereas unrecordable light adapted response. The second case had early bullseye maculopathy with atrophic foveal changes, and corresponding OCT showed foveal thinning with outer retinal loss. So ERG almost near normal except for a mild cone dysfunction. Why there is so much of functional difference? Again, the first case is a case of achromatopsia caused by mutation in GUCY2D. The second one, though not typical, it's a case of early Stargardt. She had a mutation in ABCA4. See, the once we take everything comprehensively, as just now the Sain ma'am was telling, the whole thing changes. The way we counsel the patient, for like this Stargardt, there are many preventive measures we can take, like wearing photochromatic glasses, avoiding vitamin A, which most of us don't know. To an extent, definitely prevent the progression. To conclude, most of our conclusions are almost the same. So electrophysiology should always follow clinical correlation. Don't take any investigation isolation. Additional genetic information may add strength to our correlation. So electrophysiology is an important tool to avoid misdiagnosis, prognosticate, counseling of the patient, which is most important. Because most of these patients come to us with the diagnosis, I have this, I know that, what's next? Am I going to become blind? How will how to plan my career? So we need to answer those questions. Thank you.
So we have Dr. J. Goel to tell us about another field where we are using electrophysiology, that is in glaucoma and neuroophthalmology.
Good afternoon. I will be speaking on clinical application of electrophysiology in glaucoma and neuroophthalmology. So automated static perimetry is standard method of measuring changes of the visual field, but it detects glaucomatous damage only after a significant proportion of nerve fiber bundles they have already been affected. The eyes with mild or moderate visual field defects may have lost 40% of their axons at the optic nerve head before showing the changes. Electrophysiological tests, the vulnerability of the nerve fibers to damage can be demonstrated more readily with a diagnostic method that is sensitive to their dysfunctions like pattern VEP, pattern ERG and photopic negative response. The pattern ERG and PHNR are produced by inner retina, are a functional indicator of retinal ganglion cells and are markedly affected in glaucoma. The pattern VEP is affected by optic nerve dysfunction but is affected later. We conducted two different studies, one with pattern ERG and pattern VEP in glaucoma and another photopic negative response and retinal nerve fiber layer in open angle glaucoma. Coming to pattern VEP, advanced glaucomatous damage produces a clearly abnormal VEP, but the abnormality usually is not pronounced enough to reliably detect early damage in open angle glaucoma patients. The comparison of VEP in the two eyes of asymmetric glaucoma patients may be sensitive enough to be useful in assessing progression. This is the ERG equipment we are using. This is the stroboscopic lamp for flash stimulus. This is a monitor for pattern stimulus. This is Gans field stimulator, and this is the preamplifier, and this is the oscilloscope. So the electrodes which are used are surface electrodes like silver chloride electrodes, and these are ERG jet electrodes for flash ERG and photopic negative response, and these are gold foil electrodes which we are using for pattern ERG. This is how the pattern ERG is recorded. So this is the active electrode, gold foil in the
So we
lower.
can go directly to the
This one
ERG.
is this forehead is a ground electrode, and this one is the reference electrode. So these are the electrode placement in VEP at the forehead, corona, and the occipital. Occipital one is the one which is active electrode. So our aim was to evaluate pattern ERG and pattern VEP in glaucoma suspects and open angle glaucoma. We had done 20 eyes in 3 group of the patients with 40 eyes each. But we have seen that pattern VEP is affected in glaucomatous patients. In open angle glaucoma, they are significantly affected as compared to glaucoma suspect and the normal patients. The difference between the glaucoma suspect and the normal was not very significant, but between open angle glaucoma and the patient's normal or glaucoma suspect, it was quite significantly different, both in amplitude as well as in the latency. Now you can see even with in the amplitude also, the glaucoma patients, they have significantly decreased amplitude as compared to glaucoma suspect and normal. Now glaucoma suspect, they showed bimodal distribution, one group indistinguishable from normal subjects and the other group was comparable to subjects with glaucoma. Now this is the pattern VEP, pattern ERG and VEP, both latency and amplitude in cases of open angle glaucoma. You can see that the VEP is less sensitive as compared to the pattern ERG. Pattern ERG, there was none with normal pattern ERG in glaucoma group. So in open angle glaucoma, the explanation for this probably lies in the cortical representation of pattern VEP, which primarily measures the function of the central retina. Since the glaucoma induced visual field losses in the early stages of the disease are relatively close to the central retina, the parafoveal damage can be better detected by means of the pattern ERG than pattern VEP. So pattern ERG appears to be more sensitive than pattern VEP in detecting early glaucomatous damage. Now coming to photopic negative response, this is a flash electroretinogram done under photopic condition has identified a new wave which is called photopic negative response, which originates from the retinal ganglion cell layer, which has been found to be affected in glaucoma. But PHNR has been markedly affected in primates with experimentally induced glaucoma, and the significant reduction in the amplitude of PHNR wave in open angle glaucoma has been reported in the studies by Vishwanathan et al. We have done a study on PHNR retinal nerve fiber layer thickness on OCT and was conducted on 40 eyes each in normal glaucomatous glaucoma suspect and established open angle glaucoma. This is
I think we'll have to wrap up. If you can just go to the results of the study.
PHNR, this is the photopic negative response from the horizontal to the peak of the trough of B wave. This is in glaucomatous eye, it is reduced, and comparing the 3 groups, you can see the PHNR here is much reduced in glaucoma, and in glaucoma suspect it is in between, and normal patients the PHNR is much higher. So coming to the results, amplitude less than 25 microvolt may be regarded as positive for glaucoma in PHNR. No correlation was found between PHNR or visual field, retinal nerve fiber layer or optic disc topography in any of the 3 groups. Retinal nerve fiber layer represents a structural loss, but structural and functional abnormalities, they don't go hand in hand. So in
I think we'll stop here because we were given the hall late. We've already exceeded 10 minutes, but we were given the hall late, so I think we will stop at that. And I thank all the speakers and our keynote speaker for helping us to understand electrophysiology better. And we taught some electrophysiology to our other colleagues also. Thank you.